cleaning up on the scapular examination as we look at it statically. See, he's sitting out here a little differently, and then we go through our dynamic up as high as you can go and down slowly, and we watch the scapula as to where it goes and what things it does. So the things we're looking for in here would be, you can relax right there, the static position, but then the dynamic. But in the dynamic would be outward rotation, inward rotation, forward tilt, backward tilt. Is that right? And external rotation or internal? That's internal rotation, external rotation. And then upward and downward. Have we done anterior tilt and posterior tilt? Did we do that? And then protraction and retraction. So throwers, for example, they would have outward rotation, protraction, and anterior tilt. So what happens is their shoulders go forward. Turn this way, Mark. Come on. They roll forward. So then they get tightness in the pectoralis here, and that's something we work on to bring that back out. So that's the tightness we see in that, and that's sort of the scapular implications we see. With posterior instabilities, for example, if they go up, scapular wings, the shoulder comes out the back. Now we do two tests for the scapula described by Kibler. One is a scapular assist, where if we bring them up and it hurts up here, sort of impinging area, then we simply put our fingers on the inferior scapula and ask them to do that again, just a little scapular assist, and then it hurts less. So Dr. Kibler says, well, if they have impingement at the front, I do a scapular assist, and then, whereas he says Hawkins does an acromioplasty, maybe it'd be easier to do this. Now the other is the scapular stabilization. Actually, we describe this with our scapular fusion. So what we do here is if this scapula wings, we put our hand on the front and secure it down. So if he lifts and has trouble lifting because the scapula wings, outward rotation, then we stabilize the scapula. Turn this way a little more, Carter. We stabilize it like this and then ask him to lift again, and he can lift much better when we stabilize the scapula down. If the scapula wings a lot and it's hard to hold down, if we're going to do anything with that, the only thing we can do is fuse it. If it wings a little bit, and we do rehab, of course, but if we're going to do anything, we might consider soft tissue stabilization with pectoralis transfer that goes in under here. So we went through the concept of how to feel the coracoid and scapula when we're trying to measure external rotation, for example. So as soon as coracoid scapula moves, we sort of stop. And we really put them with a little roll under here so they're in the scapular plane. So, and I think you know we have frontal, sagittal, frontal, scapula, which is 30 degrees off, and then coronal, directly through there. So those are the different ones. So we'll do this in the scapular, and similarly when we come into internal rotation, we feel here, and when the coracoid and scapula move, we stop. And then on this crossed arm, if we come across here, roll that way just a little bit, stabilize the scapula, and then we hold the scapula here and come across. So I'm holding the scapula down and coming across, and actually we'll get you straight up. And normally he comes to here. Now the scapula wants to go, so we stop before that happens. So in throwers, we hold it down. They often come to here, which would suggest posterior capsular tightness. And if they have a lot of retroversion, the arm often goes up into this position rather than straight across.